everyone, we are about to present a gestational condition called abortion or miscarriage, which refers to a medical procedure that is used to interrupt a pregnancy before a viable fetus can be delivered. So when we say viable fetus, it is one that has reached a gestational age of 20 to 24 weeks or weighs at least 500 grams. If a fetus is born before this point, it is considered a miscarriage or premature or immature birth. It is important to understand that this procedure is only performed when there is a medical condition that puts the mother's health or life at risk, or when the fetus has a severe abnormality or genetic disorder that is not compatible with life. Spontaneous miscarriage occurs in approximately 15 to 30% of all pregnancies, meaning it is not an uncommon occurrence. A spontaneous miscarriage can occur at any stage of pregnancy, but it is more likely to happen during the first trimester. To discuss the common causes of spontaneous miscarriage, we have here Mr. Diesel Malatag.
This is Diesel Malatag, and what I will present today are the common causes of miscarriage. Let's start with number one. Abnormal fetal development, which is the most common cause of miscarriage in the first trimester of pregnancy. That is the result of a teratogenic factor or to chromosomal aberration. Statistics state that between 50 to 80% of fetuses aborted early have structural abnormalities. Second cause, we have implantation abnormalities. Some zygotes never implant securely because of inadequate endometrial formation or from an inappropriate site of implantation. As a result, placental circulation does not develop adequately, leading to poor fetal nutrition and hence abortion. Third, we have poor production of progesterone. So, if the ovary fails to produce enough progesterone to maintain the decidua basalis, it may lead to abortion. Then we also have systemic infection in a woman. So with an infection, if the fetus fails to grow, estrogen and progesterone production by the placenta falls. This leads to endometrial slowing and consequently uterine contraction and cervical dilatation along with expulsion of the products of the pregnancy. Lastly, we have ingestion of a teratogenic drug. So when we call something teratogenic, it means that that substance is harmful and can cause developmental malformation for the fetus. These include drugs such as isotretinoin and thalidomide, and addictive substances like cocaine and alcohol. As for abortion's pharmacologic therapy, mifepristone and misoprostol are highly effective for medical management of early abortion and miscarriage. Now, for the therapeutic management of abortion, some of the most common management includes number one, forming a sympathetic supportive group for the moms to be able to express their frustrations. Two, perform the appropriate management and prevent complications. Number two, monitor vital signs, bleeding, and pain to notice things that may require immediate plan of care. Number four, document IVF, lab tests, and prepare for emergency surgical intervention. We also need to prepare administration of ROGAM to Rh-negative mothers for isoimmunization. Then we also have to advise iron supplementation because pregnant women are very prone to anemia. Lastly, we also have to advise refraining from sexual intercourse until next menses and advise use of barrier contraception for the meantime. Then to discuss the types of abortion, we have Miss Shane Nicole Palakay.
Threatened miscarriage. This type of miscarriage indicates the potential for miscarriage of early pregnancy loss. This might take place before the 20th week of pregnancy. For the signs and symptoms, it is scant bleeding, slight cramping, and cervix is closed. As many as 50% of women with threatened miscarriage continue the pregnancy. For the other 50%, unfortunately, the threatened miscarriage changes to imminent or inevitable miscarriage. Sometimes, threatened miscarriage may progress to imminent miscarriage if signs and symptoms present. For the management, the patient who appears to be at risk of threatened miscarriage may be advised to visit the clinic so that fetal heart sounds can be monitored or an ultrasound can be performed to determine the fetus viability. Blood samples for HCG testing can be taken at the beginning of bleeding and again after 48 hours. If the placenta is still intact, the level in the bloodstream should double in this time. Between 24 to 48 hours after a woman reduces her activities, the spotting associated with threatened miscarriage typically stops. She can gradually resume normal activities once the bleeding stops. In order to avoid infection and avoid causing for more bleeding, sexual intercourse is typically prohibited for 2 weeks following the bleeding episode. Imminent or inevitable miscarriage. It is an early pregnancy characterized by vaginal bleeding and dilation of the cervix. When a miscarriage is imminent, vaginal bleeding is worse and cramping is more severe than when an abortion is threatened. The signs and symptoms are cervical dilation and uterine contraction, moderate vaginal bleeding, severe and painful cramping, and the cervix is open. For the management, vacuum extraction, dilation, and evacuation, or D&E, is performed to be sure that all products of conception are removed if there are no fetal heartbeats heard and an ultrasound reveals an empty uterus or an unviable pregnancy. Suction curettage is performed to clear the uterus and avoid any potential issues like infection. Any tissue that is passed in the delivery room, as well as any that is brought from home, should be saved so that it can be inspected for an anomaly such prenatal trophoblastic disease like hydatidiform mole, as well as to make sure that all fetuses have been freed from the uterus contents. The patient should evaluate vaginal bleeding by keeping track of how many pads she uses after being released from the hospital after the D&E. Complete miscarriage. In a complete miscarriage, part of the conceptus, usually the fetus, is expelled, but the membrane or placenta is retained in the uterus. Take note that vaginal bleeding may last for several days and cramping is similar to labor or severe period pain. This is due to the uterus contracting to empty in order to expel the fetus and the placenta. For the management, if bleeding is severe, the woman should lay flat in bed on her side and an external monitor is used to track fetal heart rate and uterine contractions. The intake and output as well as the woman's vital signs are measured to determine her maternal reaction to blood loss as well as renal function. By reserving and weighing the used pads, the maternal blood loss is calculated. Any tissue in the pads should be saved since it might include fetal products.
Incomplete miscarriage. It occurs when a miscarriage begins but the pregnancy does not fully exit the womb because tissues remain inside the womb. The signs and symptoms are heavy bleeding, passing blood clots, increasing tummy pains, or similar to cramps or contractions. The word incomplete can be confusing for women. They might interpret that the pregnancy will continue because the miscarriage was only partially successful. So be careful not to misinterpret this term in order to foster false hopes. The management for this is that the remaining products of conception will be removed from the uterus by the doctor using a dilatation and curettage, or DNC, or suction curettage. Make sure the woman understands that the pregnancy has already ended and that the surgery is only being done to prevent her from bleeding and infection, not to put an end to the pregnancy. Missed miscarriage. A missed miscarriage occurs when a baby dies in the womb, but the mother experiences no symptoms such as bleeding or pain. Take note that for missed miscarriage, the fetus dies at 4 to 6 weeks before the onset of miscarriage and the mother is at risk for infection. It is usually discovered at a prenatal examination when the fundal height is measured and no increase in size can be demonstrated, or when previously heard fetal heart sounds cannot be heard. A woman may have had symptoms of a threatened miscarriage or painless vaginal bleeding, or she may have had no prior clinical symptoms. An ultrasound can establish the fetus has died. According to Linker on 2009, a dilatation and vacuum extraction is usually done after an ultrasound, followed by labor induced by prostaglandin suppository or misoprostol, followed by oxytocin stimulation or administration of mifepristone. The management for this is to help the womb release all of the remaining immature tissue. Medication such as mifepristone plus misoprostol is given by the healthcare provider. To remove the leftover tissue from the uterus, dilatation and curettage surgery may be required by the doctor. Recurrent pregnancy loss. It is having 2 or more miscarriages in a row. After 3 repeated miscarriages, a thorough physical exam and testing are recommended. The management for this is that patients with RPL should ideally come to the clinic together as a pair. A thorough medical, obstetric, and family history should be included in an initial appointment, as well as details about the lifestyles of both male and female partners, such as smoking, binge drinking, strenuous activity, being overweight or underweight. Certain issues with the uterus, such as excess tissue that divides it or septum, some fibroids or benign tumors or scar tissues can be treated surgically. Low-dose aspirin and heparin may be used to treat women with autoimmune or clotting or thrombophilia issues. Medications, such as blood-thinning medicines, can be used to reduce the chance of miscarriage when pregnant.
First risk factor is the age. Women older than age 35 have a higher risk of miscarriage than do younger women. At age 35, you have about a 20% risk. At age 40, the risk is about 40%, and at age 45, it's about 80%. Meanwhile, for previous miscarriage, women who have 2 or more consecutive miscarriage are at a higher risk of miscarriage. For chronic conditions, women who have a chronic condition such as uncontrolled diabetes have a higher risk of miscarriage. We also have uterine or cervical problems. Certain uterine conditions or weak cervical tissues such as incompetent cervix might increase the risk of miscarriage. Next one, we have smoking, alcohol, and illicit drugs. Women who smoke during pregnancy have a greater risk of miscarriage than do non-smokers. Heavy alcohol use and illicit drug use also increase the risk of miscarriage. Next risk factor is the weight. Being underweight or being overweight has been linked with an increased risk of miscarriage. So may I call on Ms. De Leon to discuss us about the assessment and the signs and symptoms of miscarriage.
So for the assessment, signs and symptoms of miscarriage might include vaginal spotting or bleeding. Pain or cramping in your abdomen and lower back can cause the uterine to contract to expel the pregnancy tissue. Fluid or tissue passing from your vagina, this problem should always be evaluated by a clinician. However, bleeding and discomfort can occur in normal pregnancies. In many cases, bleeding resolves on its own and the normal pregnancy continues without further problems. No longer experiencing the symptoms of pregnancy, such as feeling sick and breast tenderness. Some warning signs of pregnancy loss without bleeding include if you are having strong pregnancy symptoms that suddenly reduce or stop before you're 12 weeks pregnant, your hormone levels might be dropping. Pregnancy tests that show a negative result. You can get negative result on your pregnancy test for 2 reasons. One is you are not pregnant or you are pregnant, but you tested too early for the pregnancy test you used to pick up the HCG pregnancy hormone in your body. Next is the nausea, vomiting, or diarrhea, and also includes here the back pain. So next is we are going to assess the client. We're going to ask them questions like, in the confirmation of pregnancy, does the woman know for a certain that she is pregnant? A positive pregnancy test or a physician confirmation. A woman who has been pregnant before and states that she is sure that she is pregnant is probably right, even she has not yet had this confirmed. Next is we are going to ask the pregnancy length. What is the length of pregnancy in weeks? So in the duration, we will going to ask the client how long did the bleeding episode last or it is continuing. And in the intensity, we're going to ask if how much bleeding occurred. Ask the woman to compare it in the common measure. So we're going to ask the client to describe, was the blood mixed with amniotic fluid or mucus? Was it bright red that represent fresh blood or dark that represent old blood? Was it accompanied with tissue fragments or was it odorous? And next is frequency. Is it steady spotting or single episode? We're going to ask also for associated symptoms like cramping, sharp pain, dull pain, or had she ever had cervical surgery? And in the action was what was happening when the bleeding started? Has she done to control bleeding? And last is we are going to ask the blood type of the patient. Does she know this? Rh negative woman will need Rh immune globulin to prevent Rh immunization.
Lastly, we'll discuss the complications associated with abortion, starting with hemorrhage, which is the internal bleeding and has a higher risk of developing in an incomplete spontaneous miscarriage. The health teachings for this one is number 1, impart how much bleeding is abnormal, that is, 1 pad per hour is abnormal, and what color changes should the woman expect in bleeding. So it should be gradually changing to a dark color and then to the color of serous fluid as it does with the postpartum woman. Any unusual odor or passing of large clots is also considered abnormal. Lastly, we have septic abortion. A septic abortion is an abortion that is complicated by infection. Frequently, it occurs in women who have tried to self-abort or were aborted illegally using a non-sterile instrument such as a knitting needle. When these are left untreated, it may progress and lead to toxic shock syndrome, septicemia, kidney failure, and worse, death. To manage this one, women with septic abortion need immediate, intensive assessment and treatment because it can be so severe that the woman needs to be admitted to an intensive care setting for continuing care. That's it for our discussion.